Okay, now we're going to talk about something that's that hits everybody, right? It's insurance coverage for what ends up being very expensive healthcare costs. You know that a lot of the medicines Dr. Roberts talked about, no reasonable, even wealthy person could afford that if you had to pay for that out of your pocket. So we, you know, in the United States, we have this insurance structure where we pay premiums and expect companies like insurance companies to pay for them. So it's not as simple as that, obviously. So that's why we need experts like Becky to decipher it, translate it into like things that I can understand. There are very important things though, because they, if ignored, they often end up with you like looking at an out-of-pocket expense that you didn't expect and you can't afford. So Becky, like I mentioned, has become a national expert on this topic, and she's going to talk to you about a couple of very pertinent and very present challenges to the system. So thanks, Becky. Yeah, sorry.
All right. So I will start with, there is no possible way for me in half an hour, 20 minutes to explain everything about insurance. You know, what we deal with when you're especially looking at bleeding and clotting disorders, you're talking very, very expensive disorders to treat, very high touch, and insurance, when it comes to our type of claims, is difficult. So I'm going to go through a lot of concepts. The takeaway from this is, at the end of the day, if you're seeing any of these schemes hit your insurance or you have general insurance questions, I'm here every day. I have a team of people that are trained in how to deal with these things. So if any questions arise, just call the office. We are here for you. This is what we do all day, every day, and we're happy to help in any way possible. So when you look at overall US healthcare literacy, only 9% of the US population fully has a grasp on 4 basic insurance terms. And I have 4 on this slide. We're actually going to go through 5 of them on the next slide. This is, the good news is this has increased since last year. Last year it was only 7% that understood the basic terms. So I said, numbers, I'm an accountant, it's great when I don't do the same number of things that I say, but we're going to actually go through 5. First one is your premium. Most people think premium goes towards your maximum out of pocket. It doesn't. Your premium is just what you pay for the privilege of utilizing that insurance. So this can be low, this can be high, but unfortunately, everything you pay towards your premium doesn't have anything to do with your total out-of-pocket cost for insurance. This is just what you pay to be able to access those products. We're going to talk about accumulators in a little bit. Accumulator is a combination of the next 4 terms. You have your deductible. Your deductible is what you have to pay before any coverage kicks in on your insurance. So whatever your deductible amount is on the plan, you will pay that full amount before the insurance company pays a cent towards your care. Your copay. After your deductible, your copay is the amount that you pay for prescriptions, doctor visits, and other types of care. Now, there are times where you have copays that aren't subject to deductible. This is for preventative care type situations. You go to a doctor's office, you may have a copay that comes in that's a set amount. Coinsurance. Has anyone ever heard like you have an 80-20 plan? That means that 80% of the cost after you hit deductible is covered by your carrier. You're responsible for the other 20%. That is your coinsurance. These amounts together make up your maximum out of pocket. Sometimes you get lucky and your deductible and maximum out of pocket are the same number. Most times they're not. Typically you'll have, say, a $2,000 deductible, but your max out of pocket's $8,000. That is the maximum amount you will pay for covered services within a year. The word covered is very important there because we're going to talk about some schemes coming up where they try to say services are not covered. And if it's a non-covered service, it does not count towards maximum out of pocket. We did a study of large employers. They looked at the top areas of importance for them in managing their healthcare spend. The very top 2 things in this list are things that are very acute to our patients, which is high-cost healthcare claimants and specialty pharmacy drugs. Most drugs for bleeding and clotting disorders are considered specialty drugs. So what is a high-cost claimant? Definition of a high cost claimant is anything over $50,000. If you're a severe hemophilia patient, you're going to hit that in month 2. Von Willebrand ITP, you're going to get a little bit more time, but not much. So when we look at high cost claimant data, the average is 122,000, just over 122,000 is an average high cost claimant. Again, hemophilia patients, you're talking more like 300,000 to 400,000 for a severe hemophilia patient. 29.3 times higher than the average claimant. It accounts for 31% of the overall healthcare spend is on those high cost claimants. Top of those lists, cancer, live births. If anyone's ever given birth to a child and you look at how much that cost you, you will pass out. Blood diseases. So when employers are trying to manage costs, we know costs of everything are going up nowadays. So every employer is looking at how do we contain this healthcare cost? I will tell you, healthcare premiums in this last year went up on average 20% for employers. So how do we hold on to maintain those costs as low as possible? The first thing we saw were things called copay accumulator adjusters. So remember, we said our accumulator is a combination of your deductible, copay, coinsurance, and your max out of pocket. So when a copay accumulator adjuster is in place, it says anything you personally have not paid does not count towards those accumulators. So how many of you have a manufacturer copay assistance card for your drugs? You're on, Nplate, any of the hemophilia drugs, you probably do. And that amount was intended because they understand that your copay is significantly higher than the average copay. You're not talking a $20 or $30 copay. You're typically talking a 20% of total cost copay. So the manufacturer said, we understand most people can't afford that. We're going to give you assistance to count towards that. Well, if you have an accumulator adjuster in place, that does not count towards your deductible or max out of pocket. Let's look at a case study because I like numbers. Say John Doe has a high deductible health plan. He's lucky his deductible and max out of pocket are the same amount. Unfortunately, they're $5,000. His monthly drug costs $20,000, but he has manufacturer copay card assistance of up to $15,000. This is a very typical scenario that we see. So month 1, January, he goes in to get his medication. He has manufacturer copay cost of $5,000. That's his deductible. Insurance pays $15,000, and he's now met his deductible amount max out of pocket for the year. He doesn't pay anything for the rest of the year. The pharmaceutical manufacturer has paid $5,000 towards his copay, and his insurers paid $235,000 for that year. This was pre-2017 when we saw the first accumulator adjuster programs put in. After 2017, the scenario changes. January, February, and March, patient still has no out of pocket because now instead of using that $5,000 once that he had available, they're using it 3 times until they've maxed it out. And you'll notice the patient remaining amount doesn't change because he has an accumulator adjuster in place. So his accumulator is never touched until April when he shows up to his pharmacy and they say, okay, how would you like to pay your $5,000 deductible? And he says, I don't understand. I have copay assistance that should cover that. Well, I'm sorry, sir, you have a copay accumulator adjuster on your plan. So nothing that you haven't personally paid counts towards your maximum out of pocket or deductible. So assuming John Doe is independently wealthy, he pays his $5,000 and off he goes with his medication. At the end of the day, he's paid $5,000, pharma's paid $15,000, and the insurer's only paid $220,000. So there's a $15,000 reason why a plan would want to put this in place. Unfortunately, most people can't afford that $5,000 out of pocket that they weren't expecting. The average American can't afford a $500 emergency bill, let alone $5,000. So what we see a lot of times when these first came up is that we would have drug abandon at the pharmacy counter. Unintended consequences are that if you have a bleeding disorder, you're probably going to the emergency department when you have a bleed because you can't afford your medication. So again, high patient cost share. One of the biggest consequences of a high patient cost share is that drug abandonment. Without a deductible, 9% of drugs are abandoned at the pharmacy counter. With specialty deductibles, you're looking at 27%. when a patient has to pay that full specialty deductible out of pocket. So we did a lot of, barking about these and talking to payers, talking to employers and saying, look, you are causing unintended consequences. When you send a patient to the emergency department, you're going to be a 400% markup on that drug because now it's going to bill off of your medical benefit and you have to pay it. So they said, okay, we don't want patients to go without their drug. We don't want these unintended consequences of higher overall cost. So we'll change our approach. In comes the copay maximizer. How many people know what an essential health benefit is before I put the slide up? So the ACA defined a list of essential health benefits. Every ACA compliant plan has to cover all of these 10 essential health benefits, one of which is prescription drug coverage. This does not apply to self-insured or large group health plans. If your employer-sponsored health plan has more than 50 lives, you are now in a large group plan. Those are not governed by the ACA. Those are governed by ERISA, which is a law intended for retirement plan accounts, but actually is used for health plans for self-insured employers. In 2011, HHS issued guidance saying that large group and self-insured employer plans are not required to offer essential health benefits. However, if they offer them, they have to respect the limits on cost sharing. The only carve out that they've authorized was if there is a generic equivalent to a medication. The disease states that we treat, the drugs that we're dealing with, most of them do not have a generic equivalent. You are dealing with brand name only specialty drugs. So copay maximizer programs start out by saying, you know what? Specialty drugs are not an essential, they're not prescription drugs. They require a prescription. You have to go to a pharmacy to get them. I don't know how you say it's not prescription drugs, but they're saying it's not an essential health benefit. It's not a prescription drug. So what they're doing is they're covering them, but they're covering them as non-essential health benefits, which means the federal requirements for cost sharing limitations do not apply to these drugs. But again, remember, they don't want to stop patients from getting their drug. So they say, we're going to take that total amount. Remember, we had that $15,000. And we're going to spread your copay. Your copay on that drug is now $15,000. Magic how that happens. We're going to spread that over 12 months, and we're going to maximize the amount we're getting from that manufacturer assistance while not making the patient pay that amount out of pocket. This last thing is really important though, because we saw some people say, I don't think this is right, that the manufacturer should, have to pay this full amount or something that they should only have to pay the $5,000 deductible. If you choose not to enroll in these plans, you have no coverage. Then you'll pay the full amount yourself, and it doesn't even count towards your deductible or max out of pocket. You're just out that full amount. These numbers on the bottom are very important. 65% of commercial plans are self-funded. This number goes up year after year. We will continue to see that grow. More and more plans will go into that large group or self-funded space. 73% of them have maximizers on them. This is something that if you haven't seen it yet, you probably will. So let's go back to John Doe. Situation's not quite as bad as it was under the accumulator adjuster. He has no out-of-pocket cost at the end of the year. But notice they've taken the manufacturer cost share and spread it over all 12 months. But I will say this was the first way we saw this done. The more concerning way we're seeing it now is they're front-ending that $15,000 in January. And they're saying your entire amount is due in January. The problem is if you change jobs. So say in March, you get an opportunity to take another job. Great benefits, but you still have a deductible in that new health insurance. You no longer have any patient assistance available for your deductible max out of pocket because your other plan has used it all in January. But if you look at the total cost over here, they're not saving as much as they were in the accumulator adjuster, but they're still saving $10,000 by instituting this type of plan. And this number is important. You still have a deductible. So nothing in this, because it's carved out as a separate benefit, because it's a covered non-essential health benefit, nothing towards your drug spend goes to any of your other deductible for hospitalizations or any other medications that you may have. So again, this is just laying out those three scenarios. So you can see there's a significant cost savings to the employer for doing this. If this was where we stopped and this is all I was seeing, I would be much happier than I am today. Unfortunately, this is not the direction I think most plans are going. These two schemes take advantage of copay assistance funds. This is the manufacturer coupons. They're intended to help you with your out-of-pocket portion. Manufacturers also offer patient assistance programs. Patient assistance programs are intended for uninsured or underinsured patients. They cover, free drug. Nothing's ever free. That's why it's in quotes, but the intent is it's a short-term solution while you try to find insurance coverage. Enter alternative funding or specialty drug carve-outs. I've also seen them called specialty drug cost assistance or things like that sound really benevolent and they're not. So what is this? This is when your self-insured or large group plan says there is no coverage for your drug on your plan. I've seen specific disease states carved out where they've said there's no coverage for hemophilia medications. I've seen no coverage for orphan medications. The most recent one I saw was no coverage for any specialty medication over $3,000. I challenge anyone to find a specialty medication that is less than $3,000. It's all of them. This can be extremely highly disruptive to patients. Not only are you not having coverage through your normal pharmacy program that you would normally get your drug from, in some of the most recent iterations, you don't even have coverage if you go to the emergency department. There is absolutely no coverage for that drug on your plan. This is the list of companies that I've seen to date that do this. This is not exhaustive. There are many, many more. These are only the ones that I've seen. If you have a plan and you get a call from any of these companies, call our office because you have alternative funding in place. This one I laugh at. Sharks is my favorite. They don't even pretend not to be predatory. It's in their name. But they try to come off again as very benevolent. Payer Matrix is a team of dedicated healthcare professionals who partner with your employer to reduce the cost of your high-dollar prescription drugs. They advocate on your behalf with drug manufacturers. Sound like really awesome people, don't they? They help with cost assistance for members. Try to really help coordinate with specialty medication experience. The important part here is if you receive a letter or phone call, it is required that you participate. If you refuse to participate in these patient assistance programs, if you say, again, I don't think this is right, I shouldn't do it, you now have less than no coverage. You have absolutely nothing. This is from Magellan. Benefits members with chronic diseases. The thing I want to step back and tell you about these plans is your employer is not trying to screw you over with these. When these are sold to the employer, because I've sat on the other side of this, they're telling your employer, we want to help you with this drug spend. You have 2 patients on your plan that are costing you $3 million a year. We want to help you keep the cost down for all of your members. So we're going to help those patients access free medication. They're going to continue to get their medication the same exact way they've always gotten it. Nothing changes for them. Now, we know that's not the truth, but what your employer is hearing is that nothing changes for my employee, but I save $3 million. This is a pretty good deal. Now, there's a cost avoidance fee of up to 50% that they don't necessarily mention in that cost savings field, but up to 50% in savings on your prescription spend. Sounds really good. So I can't say that I blame employers for falling for these. Many employers don't have the expertise to understand what's going on with these. In fact, when they first came, I couldn't understand what was going on with them, and I do this all day, every day. This is an important part. All brand specialty drugs are covered by the plan. Didn't I just say patient assistance programs are for people without coverage? This has been one of the challenging pieces of this and one of the pieces that's causing the biggest issue for our patients. Because in most of these schemes, you actually do have coverage for your drug on your plan. It's just in a different spot than people would normally look. So every plan has a pharmacy benefit and a medical benefit. The drugs that we deal with can be billed on either of those benefits. When you go to submit your prescription to your pharmacy, they're checking a pharmacy benefit and they're saying the drug is denied, which is kicking it over to the patient assistance programs. When the patient assistance programs do a benefit investigation, because they started realizing, wait a minute, why do we have so many more patients on our patient assistance programs? We've got to look into this. So they did. And they know to ask on both the medical and the pharmacy benefit. And they're finding out there is coverage. Denied. We're going to deny the patent. The paid payer matrix, paid health, any of these lovely benevolent people will say, no, they don't have coverage. And it becomes basically a peeing contest between the manufacturers and these brokers and payers. Has unintended consequences though. Manufacturers limit eligibility. We now have seen most of the manufacturers within the hemophilia space say, if you have any coverage, or even if you have an alternative funding plan in place, if they can identify that maybe you don't have coverage, but it's because of alternative funding, you do not qualify for the patent. Increases the cost for those that can pay. You know, basic economics, if you own a business and 50% of the people using your business can't pay for their product, what do? You raise the cost for the people who can pay. Unfortunately, the small group plans have to pay for them. Medicaid and Medicare have to pay for them, which at the end of the day means every person in this room pays for them through their taxes. And most importantly, patients are left without access to drug. I can tell you that we have had a patient who we provided over $800,000 worth of drug to for free because he had no other way to access it. Now, I continue to fight on behalf of that patient and others with this, but this is what terrifies me. And it gets better. AbbVie, so this isn't just happening in hemophilia, this is happening in cystic fibrosis, cancer, arthritis. The list goes on and on. I sit on a national task force of advocacy groups that specifically work on this. So AbbVie started suing. They said, these people are taking advantage of our PAP, we're suing them. So they have sued Sharks, or Paramatrix, sorry, they sued Paramatrix. Paramatrix responded, meritless lawsuit. They're a patient advocacy company, friends. That's all they do is advocate on your behalf. Sharks files a defamation suit. Paid Health has actually sued a patient advocate for defamation. We're going out and speaking to what they're doing in these plans. So what can you do? This is like terrifying. No one wants to see one of these hit their plans, but the reality is they can. And if I could guess, in the next 5 years, they will. Biggest thing I can tell you is be careful when you're choosing your health insurance plan. If you have multiple options with your employer, look at them. Look at those plans. The summary plan descriptions are the biggest tell of when these plans are in place. If you don't know how to look at it, you're not comfortable, call our office, call our team. This is what we do. We're here to do this. I sit down with these all day, every day, like Dr. Tarantino said, not only here, but throughout the country. I look at plans and try to help patients determine what's in their plan and what they're really looking at. Advocate for yourself with your employer. Like I said, most employers want to do right by their employees. They don't understand the actual consequences to their employees. I have so many people tell me, but I don't want my employer to know that I cost them that much. They already know. As a large group employer, they absolutely know how much every single person on the plan is costing them. So the idea that they don't know is not correct. They absolutely know. And a lot of times I've heard from employers that they appreciate that the employee is trying to come to them and say, look, I want to be part of the solution to my healthcare costs. I'm going to help you find the best way to manage my cost. Advocate to your elected officials. I know, Nicole's probably down with the kids, but Nicole Spangler's been with us to DC before. If you're interested in advocating to your local legislators, whether in Springfield or DC, please call Marcia. We take a group out to DC a couple times a year, and we go to Springfield once a year and talk to lawmakers about this. I actually met with the Department of Labor and the FTC, IRS, and EBSA on this, looking at ways we can stop this, because I would argue that not only do we probably need legislation on this at some point, it's actually violating current laws. So we're working with the feds and our state legislators to really find solutions to this. If you do find one of these schemes in your plan, call us ASAP. The quicker we know these are happening, the quicker we can try to find solutions that will help you. The last thing I want is one of our patients to end up in the emergency department and have a bill that they didn't see coming because there's no coverage for their plan, or they've got a maximizer in place or an accumulator adjuster. Just let us know as soon as you see them, and we will work with you to try to mitigate any potential consequences as much as possible. So I threw a ton of insurance stuff at you. Does anybody have questions? Yes.
I currently have Blue Cross Blue Shield. Everything's been covered very well. I also have Medicare because of age. I've not retired. Unfortunately, they want me to leave, but, through the union, I can keep my job 2 years. We're coming up to the end of 2 years where I'm going to be forced to retire. What scares me is I'm covered very well with the Blue Cross Blue Shield. I'm being told, I believe it's Humana, through my pension, that it's basically the same. Well, no, it's not the same. I don't, from what I'm seeing, but here at the end of this year, I'm gonna have to make that change. And I'm kind of afraid that I'm gonna get slammed like you're talking.
So the good thing is Medicare has to be compliant with federal rules because it's a federal program.
Okay,
So they cannot put a lot of these things in place, but I have seen a lot of utilization management in the Medicare plans that basically just makes it very, very hard to utilize that. So I would talk to Marcia or myself and call the office. We can work through, once you get details on what that plan looks like, we can kind of work through it with you and give you an idea of what that's going to look like and what other options we have. The other thing with Medicare is some of the assistance stuff can't be used in Medicare plans, but there are things that can be. There are third-party organizations that can do assistance for Medicare.
okay.
So call our office. We can help you try to
Right, yeah.
identify those.
I just hate to change horse in the middle of the stream.
It's
And
terrifying.
that's what, they're trying to force me, but it's like, no, I'm gonna ride this all the way to the end.
Well, and that's important. Even without a chronic condition, making a change in your insurance is terrifying. You don't know where you're going to land. You don't know what things really look like until you start utilizing it. That's what we're here for. Please, please, please call us. Utilize the services we have. Nothing makes me happier than making insurance companies pay for stuff. So
I went through a nightmare at the hospital, them changing my carrier in registration. And what a nightmare that turned into. Not once, not twice, 3 times. They put me down as having Humana, United Healthcare, and then just Medicare. And I'm like a small community in Princeton, small hospital. And they're like, no, you're not covered. Oh, this isn't authorized. I'm like, what are you talking about? I'm like, why do you change? Now I know, because they're training people in registration. As soon as they just ask a couple of questions that should never be asked, I'm like, stop right there. Stop, get somebody else in here. And I do make them go get a supervisor and stop it. But it took three times of getting hit like that.
absolutely. When things like that come up, call our office.
Okay.
Even if it's not related to your bleeding disorder, I can look at a plan typically and
Right.
tell you hey, these are the things you have to be careful of. And we can kind of work through that and help you
Right.
advocate and connect you to resources.
The end plate, they're like, hey, that's not authorized. And,
All right. Well, obviously, that's a topic that isn't encapsulated within this room, right?
right.
The discussion can certainly go on outside of the room, and like Becky said, Becky and Marcia are great resources for that, and we're always available to you